Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm very pleased today to be talking with Dr. Daniel Hofer, a family physician at Sharp Steely Medical Group. He's also Chief Medical Officer, Outpatient Palliative Medicine, and Medical Director for Sharp Steely Hospice Care in San Diego, California. Dr. Hofer, thanks for joining with us today, and I'm turning things over to you.
Thank you again, Larry. This is the fourth presentation in the series of 6 presentations, and today we're going to be talking about delirium prevention. This is the follow-up from the previous presentation, which discussed the importance of delirium. And what we learned there is that delirium is highly undervalued. It's misdiagnosed. It's frequently missed about 65% of the time. And the consequences of delirium are significant. So we learned that the mortality rate for delirium in the advanced elderly is as bad as sepsis or a myocardial infarction. The long-term mortality rate's as bad as advanced cancers that are incurable, as well as end-stage heart failure. And if the patient does survive, we learned that delirium is highly associated with significant functional and permanent cognitive decline, including being diagnosed with dementia at a rate 12.5 times higher if the patient develops hospital-induced delirium. So with all that information, just like with heart attacks and cancer and strokes and heart failure, we want to do everything we can to prevent delirium and keep grandma the way she was. So let's go ahead and get started, and we can go on that journey. These are my disclosures. I'm a paid consultant for all of these groups. This should not interfere with what we will talk about today. So the first thing I can tell you about preventing delirium in your elderly population is to know the harms of the medication list that you have before you. And these are medicines the patient may have been on for decades, but at this point in their life can become particularly harmful. In that list of medications are anticholinergic medicines, the worst category of medicines, although there are other high-risk medications that we need to be worried about. Specifically looking at anticholinergic medicines, I want to show you this study from New Zealand. This is a socialized country, and other socialized countries have validated this information. They can monitor the anticholinergics prescribing to their population. And what they found in the elderly per year is that per point of anticholinergic burden score, and medicines are scored on a scale of 1 to 3, there is a 10 to 12% increased associated risk of falls, hospitalizations, doctor's visits, and mortality per ACB point. So if a medicine has a score of 3, that's a 30 to 36% increased risk of mortality or falls or hospitalizations. There's also longer lengths of lengths of stay in the hospital and institutionalization. But perhaps most importantly for those patients that survive, that there is a 13% increased risk of being diagnosed with dementia per point of anticholinergic medication. That means for a medicine such as oxybutynin, tiotropium, any of the tricyclic antidepressants, bladder or colon antispasmodics, those patients have 26 to 39% increased risk of being diagnosed with dementia just by being on those medications. This is a study published out of JAMA just a couple of years ago, going from delirium directly to looking at dementia. And they looked at the anticholinergic exposure to certain drugs, mild exposure, weaker anticholinergic drugs to more stronger anticholinergic drugs, and they found the same result, in about a 6% to a 49% increase in being diagnosed with dementia for patients that were on these medications. That was an odds ratio. So what's the mechanism? What we think is that there is some form of neuropathology, neuroinflammation going on. Lots of surrogate markers. We have been able to prove, for example, that in animal studies, anticholinergic medications upregulate tau protein, and tau protein's the other part of the equation for Alzheimer's disease, the neurofibrillary tangles. There may be other mechanisms as well, but I think what this is pointing out to us is it's no longer that easy to say it's just an association. It may in fact soon be relegated as a causation And we all need to be aware of that, because the question will be is, are we making our patients demented by too many medications? This is a typical list of anticholinergic medications, a score of 1 on the left, score of 3 on the right. And look at the categories that are typical of these medications: antidepressants, antihistamines, antipsychotics, antispasmodics, all sorts of medications that we use all the time, even ones we're not used to thinking of as anticholinergics, such as antiemetics, blood pressure medications, all sorts of things. And we use these on a daily basis. Many of our patients, if not most of them, have some form of anticholinergic burden. If you're looking at a list of patients' medications and you get a board question, the most important concern regarding a patient's risk of developing hospital-induced delirium or delirium is not the medication category, but it's polypharmacy. And that is 6. And I'm telling you that is 6. 1, 2, 3, 4, 5, 6 or more medications increases the patient's risk of developing delirium by 14 times. If you look at the category, which is the highest risk, it's anticholinergic medications, about 4.5 to 12 times higher, and sedative hypnotics about 3 to 12 times higher, followed by antipsychotic medications and any type of psychoactive medications, and then opioids. Opioids do have a dose effect, but of the categories of medicines, the ones we are concerned about are anticholinergics, sedative hypnotics, that includes all the Z medicines, the zolpidem category, and psychoactive medications of any type. So just to show you the significance of anticholinergic medicines, when I'm giving this talk to a live audience, I look to the left and say, well, the left side of the group was so excited to come hear this presentation. They wanted to get good rest. So the last 90 days, they've been taking Tylenol PM every night. And the right side of the group kind of knew that there was something wrong with doing that. So they avoided taking any medicines and they used non-pharmacologic management. And all 3 of the next studies were comparing patients with a ACB score of 0 or patients with a ACB score of 2 or 3 based on being on 3 medicines with a score of 1 or 1 medicine with a score of 2 or 3. And in the group taking the Tylenol PM, the score of 3 with 1 medication, the odds ratio after 90 days of being diagnosed with mild cognitive impairment was 2.73 times higher. After 2 years, the group taking Tylenol PM had a statistically significant decrease in their MMSE scores. Now, it's not huge, but it's not 0. And that's 2 years. Over the course of 10, 15, 20 years, that's a significant drop that would be highly associated with that person being diagnosed with dementia. And if they went for surgery, the odds ratio of developing postoperative delirium went up by 230%. And we discussed last presentation the significance of that type of information. So this is another study looking at all of the categories of medications prescribed to typical populations. And you can see these are the antihistamines, the antispasmodics I was talking about, the antidepressants, the muscle relaxers, medicines that we simply use on a daily basis to help acute problems in our patients, especially when they're younger and healthier and do not appear to have any cognitive effect. However, when we looked at the total standardized daily dose over a 10-year window in the elderly, that was not quite as clear that these are as beneficial, or at least didn't carry a significant risk to cognitive decline. And what we found, if you look at the left, is patients with an ACB score of 0 on the top, all patients combined with an ACB average on the bottom over a 4.5-year window. You can see the greater risk of being diagnosed with dementia in that group that had anticholinergic medications. On the right, we broke it down to weak, moderate, and high-dose anticholinergic exposure. And you can see a dramatic delta in the risk of being diagnosed with dementia between the group that did not have any anticholinergic burden and the group that had a significant anticholinergic burden. And that is iatrogenic because it's from the medicines that we are prescribing them. However, what was particularly important about this particular research article, which has been validated, is that if you took a patient and had them take anticholinergic medicines in the first 3 years of this 10-year study, and then they stopped for 7 years, and you compare them to people who took no anticholinergic medicines for 7 years and started them in the last 3 years, the risk for dementia was precisely the same. That means if you stop these medicines, it does not reverse the damage. So it appears to be the total exposure to these medicines over time that is what we are concerned about, and not that you can just give them for a short period of time and then stop them and expect to go back to where the patient was before. That, of course, raises once again, via our medications, our medical management, because of our at-risk population, is it possible to treat an organ system disease problem without making a geriatric syndrome worse? This is exactly the same as frailty. And once we start to appreciate the significant number of geriatric syndromes that we're dealing with the advanced elderly, we're going to have to take a second look at how we manage this demographic, because the risk-benefit equation is markedly different. Now, there's other risk factors for dementia. ApoE gene, I think we all know about that, and lifestyle. But one of the lifestyle issues that you can get involved with your patients to keep them from having postoperative delirium and its association with dementia is physical activity. This particular study, again, published a couple of years ago, physical activity defined as leisure activity, 6 or 7 days per week of doing things such as cleaning the house, working in the backyard, working on the car, those types of activities, cleaning, shopping, cooking. Patients who were regularly active in this study, 132 patients, 31% developed postoperative delirium. For those patients who were physically active, they had a 74% decreased risk of developing postoperative delirium. That is a profoundly low odds ratio of 0.26. However, what's particularly interesting about this study is almost all of that benefit was in women. So women in particular need to remain active prior to going to surgery. I am elated when my orthopedic surgeons say, well, we can't get your patient in for surgery for 2 to 3 months because I can get my patients exercising. And the odds ratio for women dropped to 0.08. That's a 92% decrease in the risk of developing postoperative delirium. And there was a benefit for men, 0.93, but men mostly have, or usually have, more muscle mass. And as we talked about in previous discussions, muscle is secreting anti-inflammatory cytokines, and that may be the mechanism for the benefit. So that's medications, a little bit about exercise. What about medically structured programs that you can do in your hospitals? And we know that these have existed for some time. I'm just going to show you the benefits. This is usual care versus intervention group, and 50% of patients in usual care develop delirium, 32% in the intervention group in this particular study for hip fractures. Severe delirium dropped from 29% down to 12%. So obviously intervention does matter. And this is medical intervention. What's medical intervention look like? Well, here's a slide. I hate it when presenters put slides up like this, so I've broken it down for you so you can see the categories. And it's adequate CNS oxygen delivery. Now, most of us try to keep our patients' O2 sats above 92%, but to prevent delirium, it needs to be higher. This particular article put it at 95%. Doesn't mean we keep it there for prolonged periods, but long enough to help the brain to recover. Fluid and electrolyte balance is particularly important. And unlike the younger and healthier population where there's a move not to do laboratories prior to surgery, that is not the case for the elderly population. Significant risk of letting them go to surgery with electrolyte abnormalities, low albumin, other prognostic markers that we need to be correcting as best we can prior to the patient going to surgery. We should be treating severe pain. And that's not just prescribing opioids. That's non-pharmacologic management. That's using things like gabapentin or palliative strategies for neuropathic pain, but things that we can do to hopefully avoid overburdening the elderly brain with opioids and anticholinergic medications. I will say this in every single presentation. We need to eliminate necessary medications. There are clinical guides for proper de-intensification of care for the advanced elderly. That includes keeping hemoglobin A1Cs above 7, keeping blood pressures higher. The nadir of mortality per decade goes from 110 up to 140 when you go from about 60 to 80 years of age. People need to be aware of that and let those numbers rise. This is not the younger and healthier population, and people need to be up to date on the de-intensification of care protocols. And of course, it means eliminating medicines that have anticholinergic burden or unnecessary medicines. Regulations of bowel and bladder, so we want to get the Foley catheter out. Of course, if they can't urinate, we keep it in, but we get them up and moving. Try to avoid medications that will inhibit their bowel and bladder function. Adequate nutrition, which of course should have started in the outpatient arena, but also in the inpatient arena. Early mobilization and rehab. That means getting the patient out of the bed as quickly as possible. And that means immediately if you can. There are actually some studies in Spain where they do hip repairs, and within hours they have a patient on an exercise bike. These patients have better outcome. There is nothing good in the advanced elderly about lying patients flat. Of course, we want to prevent and detect early blood clots, heart attacks, hypoxia, low blood sugars, all of the usual things we do after a major procedure. We have to have the proper environmental stimuli. That doesn't mean just too much stimulation, it means understimulation. Patients need to be able to reorient, and we need to treat agitated delirium. And I want to talk about that for a second, because there was a recent article that the prevention of delirium in the ICU, there was no benefit using antipsychotics. But the structure of that recent article did not define hyper and hypoactive delirium as needing different pathways. So hypoactive delirious patients were getting more and more antipsychotics, which they probably never should have gotten in the first place, because most antipsychotics have some form or some level of anticholinergic burden anyways. So treating agitated delirium, absolutely. We use Haldol, but for hypoactive delirium, we look to stop medications, look for infections, and try to properly stimulate the patient. What we know is that intervention does matter, but that's from the medical side of the equation. We've talked about medicines, we've talked about physician intervention in the hospital, but what about nursing programs? These are also extremely powerful. And there's two that we should know about: the niche program and the HELP program. The HELP program is the Hospital Elder Life Program. This has now become an international program that's so effective. I'm going to show you some of the research from around the world. This is from Sweden. They educated the staff about delirium prevention protocols. They had about 400 consecutive patients aged 70 years of age and older. They were either admitted to the ward that was trained about delirium prevention or the usual care ward. And in the ward that was trained about delirium prevention, at 1 week, they had half as many delirious cases. The length of stay for these patients was about 4 days less, dropping from 13 down to about 9 days. And for delirious patients, it was a week less. And the mortality rates dropped from 2 deaths in the intervention group. It was up to 9 deaths in the usual care group. This is a study out of China, HELP protocol versus usual care. Median age was 75, 74.7 to be specific. The postoperative delirium in the HELP protocol group was 4 patients, 2.6%. For usual care was 19.4, 25%. That's a huge drop. ADL deficiencies were were about half. IADL deficiencies were half that in the HELP protocol. Cognitive decline using a different cognitive decline protocol was markedly less, only a decrease in 1 point versus 8 points. And lengths of stay, once again, were 4 days shorter, about 25% shorter in the HELP protocol intervention group. Now, many of us have heard in our training that you can prevent about 30 to 40% of delirium cases in the hospital, and that's true. But that's true provided the only thing that you do is provide nursing intervention. If you do all of the things that we are talking about, we should be able to markedly decrease the rates of delirium that are occurring in our hospitals, and I would personally estimate that's about 70 to 80% of the cases. This is just looking at nursing intervention. This was the original research article by Sharon Inouye. The intervention group and using health protocol was 9.9%, and the usual care group was 15%. So if you want to know where that comment came from in your hospital that you can control delirium by 30 to 40%, it came from this particular research article. But those of us who work in this arena believe that we can actually prevent markedly more delirium in the hospital than we have been previously taught. What's in the health protocol? We've talked about 3 studies now. Well, it's proper levels of cognitive stimulation and reorientation. So these patients were trained to have volunteers, nurses, physicians, staff to discuss issues that were meaningful to the patient. So the news, sports, events that were particularly important, family events, birthdays, holidays, use non-pharmacologic sleep protocol. I cannot overemphasize that. We do everything we can in the hospital in usual care to wake our patients up at night, destroy their sleep cycle. That is particularly harmful in delirious patients or patients at risk for delirium. And I've encouraged my hospital association, and hope other organizations will follow, to create a do not disturb sign where the nurse puts the time that the protocol started and the time that you can start going and checking blood sugars and blood pressure in the morning. But these patients should have at least 6 to 7 hours of uninterrupted sleep so that they can take on the next day's interventions and remain cognitively intact. They should be mobilized early and often. Can't say that enough. So get out of the chair, walk down the hallway with the family and patient support systems, but anything to keep the patient from just sitting and lying in bed. Of course, we want visual and hearing assistance, but don't forget CPAP and other equipment that would help the patient to reorient and feel better. And then we should be preventing dehydration. And it wasn't just putting a bottle of water in the room with the patient. It was having the volunteers, the nurses, the doctors, having the patient take a sip of water every single time they went into the room. And this is the results. Usual care on the top, intervention on the bottom. You can see there's a significant benefit from nursing health protocol. Reorientation is particularly important. I'm just going to talk about this briefly. Patients are in the ICU. It's a little bit difficult to do some of the health protocol, but reorientation is not as difficult as you may think. Bringing in music the patient enjoys listening to, bringing in pictures and photographs, putting people in some form of street clothes helps people to feel more like human beings and to reorient to their previous level of function. That's from the ICU. I scoured the international literature to find evidence sending patients home would prevent delirium. And those articles do exist, but they're very, very small studies. So I wanted to use this one instead. It's an older study, 536 patients, age 65 years and older. These are people who were discharged again after a hip fracture. And what were the factors for a weak recovery? It was older age, longer hospital stay, rehospitalization, cognitive issues such as delirium, dementia, and depression, poor eyesight, institutional discharge, a major fall in number of hospital physical therapy sessions. But what I really wanted people to see is this: the factors associated with better recovery, because these issues tend to be undervalued when we're discharging a patient, is reconnecting with one's social network. Patients don't reconnect with their social network when they go to a skilled nursing home, to a rehab facility. In fact, it's a second disorienting event. And so we should be doing everything we can to get our patients home and forewarn the family when the patient comes in to plan on discharge and be ready for that patient to go home immediately. There was a strong association with recovery and psychosocial factors, and most of the beneficial psychosocial factors did not exist in the hospital or the rehab facility, existed in the patient's home. So I'd like to emphasize certain issues about keeping patients adequately prophylaxed against delirium. The number one is family presence. That's a part of the reorientation process. And I can tell you, when my mother broke her, or had a second knee repair, she didn't break her knee, she had a second knee replacement. My brothers and I set up a 24/7 vigilance in the hospital so that she would be able to reorient to one of her family members if she woke up or became disoriented. And we happened to be fortunate because she was able to be admitted to a hospital that had a bed where she could stay in, but family presence is particularly important. This has been a disastrous problem during COVID because families can't even go into the hospital. And it's something we're not aware of, but it's causing unintended harm to our patients by not being able to be physically present. It's okay to be on a cell phone with, FaceTime or a Zoom visit, but it is not the same as holding your loved one's hands or being in the same room, watching a show together or reading a book, talking about life and family events. Non-pharmacologic sleep protocol should become standard across the country for all at-risk patients. Mobilizing the patient should be something we do immediately, and I'm going to show you a slide later on about the significance of this, how we are making our patients institutionalized by lying them in bed. And we should make every single effort we can to send these patients to their home and not just to a rehab facility or a skilled nursing facility, because they're there and it's easier to send the patient out of the hospital. However, what's interesting about preventing delirium is it does not start in the hospital. It's not about after they've had delirium. It's about using prehabilitation programs, because the prevention of hospital-induced delirium starts in the outpatient arena, and this is particularly important for primary care physicians. If you're taking care of elderly patients, you need to be looking at these issues even before there any consideration of them going to the hospital or going for a surgery. So this is the prehabilitation form. I give you permission to rewrite this form for your own organization. You need to be having your patients participate in exercise prior to going to a surgery. You need to have proper nutrition to get their albumin as high as you can and to prevent electrolyte disturbances. Even if they have a normal albumin, it's better to get the albumin higher if you can make that happen, because outcomes will be better if the albumin is at a higher level. You need to be sure that you are preventing constipation, so clean the bowels prior to going to surgery. Many of the medicines we give will constipate our patients. That is a common cause of readmission. The hospital stay should consider having some form of family presence, and be prepared to discharge the patient as soon as they are ready to leave the hospital. Medications should be reviewed. We've talked about that many times, and patients need to be well hydrated prior to going to the surgical suite. There are other things you can do to prevent delirium in the hospital. These are general admissions. Promalteon, which is a melatonin agonist for all admissions on patients aged 65 years of age and older, was shown to decrease hospital-induced delirium from 33% down to 3%. That is a huge drop in delirium cases just by putting them on a medicine. Now, most people will think the medicines I'm talking about are for sleep, but in this case, we're talking about using these medicines for delirium prevention. So even if the patient says they didn't sleep particularly better with these medicines, you keep them on these medicines to prevent delirium. But if you're going to use a melatonin agonist, why not just use melatonin? And the research studies that looked at this at physiologic levels of melatonin given to patients on all admissions, 0.5 milligrams, dropped the rates of delirium from 31% down to 12%. Now, we don't have a 0.5 milligram pill. We've talked to our compound pharmacy, and they said we could do it, but it's very expensive. And I've spoken to many providers in this area, and they see no reason not to use a 3 or a 5 or a 10 milligram melatonin tablet to prevent delirium. I did review some research about trazodone. Probably not enough evidence to say it's really great for delirium prevention. But if you have to have a fallback to help somebody to sleep, I would go to trazodone next, because it may also prevent delirium. What about surgical medications? These are perioperative antipsychotics. By the way, all of this is off-label. But the perioperative antipsychotics, immediately people say antipsychotics, I'm worried about those and all of the side effects. This is not the 35 milligrams of ICU use where you need to evaluate the QT interval and have them on a monitor. This is not the nursing home 1 year use where the mortality rate goes from 2.6 to 4.5%. This is 1 or 2 tablets only. So in one study of ICU use post-operative for cardiac procedures, the delirium rate dropped from 31.7% down to 11.1%. In orthopedic cases, using olanzapine 5 milligrams in the preoperative suite and 5 milligrams in the recovery suite, the delirium rates dropped from 40.2% down to 14.3%. These numbers needed to treat are in the range of 4. That is incredibly low. And in the olanzapine group, these patients were more likely to be discharged to home. And coincidentally, this is exactly what I used for my mom, who had a fantastic outcome after her surgery. In fact, we did all of the things I've mentioned so far and more. And just as a case study testimonial, my mother had finished with home health very quickly and was sent to outpatient physical therapy. And within less than 2 months, her physical therapist volunteered to my 83-year-old mother, who had her second knee replacement, that she had never seen anybody of her age recover so quickly and so effectively with so few side effects. These are the Haldol studies. Some people are aware of these. There are several studies that show benefit. Several studies show no benefit. I think the issue is that we just haven't found the proper dose. Meta-analyses have shown perioperative antipsychotics to be of benefit. There's other things that we can do. Dexmedetomidine, which is an anesthetic that has less anticholinergic delirium induction, is a great medication to use for people who need anesthesia. I would recommend it to the anesthesiologist, and I write these in my notes, in my preoperative clearance notes. Postoperative IV acetaminophen has been shown to be of some benefit. Vitamin D, a lot of people aren't aware of that. And vitamin D, interestingly, has lots of research coming out that it may be a benefit to prevent COVID. And it likely has to do with the neuroprotective effects. And then, of course, there's B vitamins, but that's usually for alcohol-induced delirium. Here's a meta-analysis, 18 studies of patients 18 years of age and older, looking at postoperative delirium for cardiac surgery, odds ratio of 0.41% if they were using Dex versus usual anesthesia. Non-cardiac surgery was even better, odds ratio of 0.33. This is vitamin D levels. This is the biobank, 351,000 older UK patients who volunteered to participate in multiple studies to evaluate biometrics and improving outcomes. And they looked at vitamin D levels in association with hospital-induced delirium. And if you're insufficient or deficient, the hazard ratio of developing delirium, just looking at vitamin D, was 2.49 times higher. For therapeutic levels, low normal, but still normal, it's the ratio of hazard ratio of 1.38. And vitamin D levels of 50 or higher, 50 nanograms per deciliter, was the standard. But what's interesting too is there was genetic variants that showed that vitamin D sparing genes lowered the hazard ratio of delirium to 0.8. So there's a lot we can do. These are the studies looking at the sufficient, insufficient, and deficient categories. Deficiency on the top, insufficiency in the middle, and then sufficiency on the bottom. Those are the rates of delirium. So one last set of slides in this presentation. So what happens when they're out of the hospital, they're out of the pre-surgical evaluation zone, and now they're in the nursing home? This is called the cascade of dependency. I encourage everybody to read this research article by Morton Creditor. When you lie an elderly patient flat, you cause tremendous physiologic change. That causes these patients to have cognitive changes, depression, psychosis, delirium. They decrease their tidal volumes and get pneumonia. They have a 50 times greater increased risk of bone demineralization. They have fluid redistribution and vascular instability. They lose 5% of their muscle strength per day. So every single day you're lying your patient flat, you're creating this cascade where the patient will end up institutionalized and in a nursing home. If they develop delirium, you can tell the family this. Their ADL deficiency at 1 month, the light gray bar is no delirium. The dark gray bar is full delirium, no resolution. The middle is resolution or improved delirium. The ADL deficiency is about 80% at 1 month for delirious patients versus about 33% for those without. The ambulatory decline is over 70%, about 73% versus about 16-17% if they don't have delirium. And the mortality rate at 6 months for delirious patients is over half of those patients versus about 12% for patients that did not have delirium. It's another study looking at 85 rehab facilities, 551 patients. Now remember, rehab facilities, these are the healthier of the patients we send to rehab facilities. Because to go to a rehab facility, you have to be able to participate at least 3 times a day with a higher level of function. And what they found for these post-acute care patients is the prevalence of delirium on admission was about 23, so 1 out of 4 patients. They looked at these patients a week later, and 36% either had resolved or fewer symptoms, 64% had the same number or more symptoms, 4 had new symptoms. But in patients with the same or worse delirium, there was significantly worse ADL and IADL recovery than those with fewer resolved or no symptoms. That was adjusted for multiple comorbidities. If the patient had persistent or worse delirium, there was little or no functional improvement. Why is that important? Because I spent almost 3 decades working in nursing homes where families were discharged to the rehab facility being told they would go back to their previous level of function, and there was no evidence that was actually the case. These patients were not forewarned, and the families were emotionally distraught, as was the patient, to find out that the best they were going to do is probably a front wheel walker. Just to give you something more concrete regarding delirious patients, these are living conditions before admission and 6 months later. Non-delirious patients, independent living, just a little decline, 26 down to 24 patients. Institutional living went from 13 down to 11. And the reason you see a drop in 2 in both categories is because 4 of the 39 non-delirious patients died. Well, guess what? 4 of the 15 delirious patients also died. So once again, it's about a 250% increase in mortality if you're delirious. But what's particularly important is only 1 of the 7 patients living independently remained independent. And of all the other survivors, they were living in an institution. What about the need for a walking device or walking assistance? Non-delirious patients, 5 of 19 patients had no walking aid at 6 months. A cane or a crutch was 7 versus 3 patients in the non-delirious group. Front wheel walker went from 17 to 20. And at 6 months, there were 3 patients that were either wheelchair bound or bed bound. But for delirious patients, there were no patients who walked independently. There were no patients who only used a cane or a crutch. All of the survivors were either using a front wheel walker, a wheelchair, or were bed bound. And you knew that in the hospital when they developed their delirium, and you knew that as a family physician or primary care physician that they were at risk of delirium before they went for their heart replacement, their hernia repair. You send them to the hospital for their pneumonia. They could have been forewarned of the consequences of the intervention they may have chosen to engage in. So here's one last slide showing you what happens in the nursing home. It's exactly the same thing as in the hospital. More complications with delirium patients, 41 up to 73%. 30-day rehospitalizations go from 13 up to 30%, so significantly higher. Discharge from post-acute care goes from 30% for delirious patients and 73 for non-delirious patients. And once again, the mortality rate for delirium patients in this case is 500% higher. 5.7 goes up to 25%. Few last pearls. It's very common to mistake hypoactive delirium as depression. This was a study of a hospitalist who referred patients to psychiatry for depression. Turns out 42% had hypoactive delirium. Distinguishing delirium from depression and dementia can be difficult. Here's a slide you can review. I would add 2 other diagnoses that physicians should be aware of: grief and psychosis, because they all are very similar, but they can be distinguished. And one of the problems is you can't make the diagnosis of dementia in the hospital. If they weren't demented before they came in, don't make that diagnosis in the hospital, or after hospitalization, they may have persistent hypoactive delirium. And treating delirium as depression can actually be harmful, and you would have to own the consequences of that harm. So this is the last slide. It does not matter where you engage in the patient in the prevention of delirium. Outpatient, primary care physician, hospital provider, post-acute care. There's significant things we need to be aware of, the risks of delirium, how to prevent delirium, the unintended consequences, and we can all engage in protecting our patients and advanced elderly patients' cognition. And so with that, I say thank you very much. I hope this was helpful to your practices, and have a wonderful day.